Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. In today's episode of Mapping Healthcare, we're tackling a global crisis that the World Health Organization calls one of the most pressing threats to human health: antibiotic resistance. An antibiotic is a substance that kills or stops the growth of bacteria. Antibiotic resistance is when bacteria evolve to withstand the medicines designed to kill them, making infections harder or impossible to treat. And the scale of this problem is made worse by our habits. About half the time that we use an antibiotic, it might not actually be needed, or it's the wrong one for the job. And that misuse is what's driving the resistance. There are efforts around the world to make sure that antibiotics are used when they're actually needed. The term for this is antibiotic stewardship, making sure that the right drug is used for the right bug, for the right patient, and for the right duration. To make it work well, antibiotic stewardship needs the support of hospital leaders who give pharmacists and infectious disease specialists time to do this. So you need boots on the ground, and this is where one of the most effective tools of antibiotic stewardship comes in: handshake rounds. It's more than just a friendly chat or a literal handshake. Handshake rounds are real-time, focused, brief, face-to-face collaborative discussions right at the point of care, where infectious disease specialists and pharmacists give feedback to treating clinicians in wards or in intensive care units on the best dose of a medication, whether to adjust the dose to avoid complications, change to another antibiotic, or switch from an IV medication to one that the patient can swallow. Handshake stewardship falls into a category of change management strategies called audit and feedback, and it has the power to change behavior instantly. And central to all of this work is pharmacy expertise. Pharmacists help figure out dose adjustments. They develop their hospital's antibiotic treatment guidelines based on antibiotic resistance patterns in their community. They flag duplicate treatments, and they drive that crucial transition from IV to oral medications, which cuts costs and infection risks. Another effective step is the antibacterial timeout. This is where the healthcare team pauses and reassesses the patient's treatment plan a couple of days after the antibiotic is started and when more test results are back. They take a hard stop and ask, does my patient actually have an infection that needs antibiotics? Do I need to order any more tests to confirm that? Can we stop the medication or switch to a shorter or safer treatment? Basically, not relying on memory or informal checks, but integrating a structured review by routinely asking these questions during rounds every day. Our guest on today's episode of Mapping Healthcare is Dr. Facundo Jorro-Baron, a pediatrician who specializes in critical care and emergency medicine with over 2 decades of experience working in public hospitals in Argentina. His research focuses on ensuring that effective medical treatments reach low and middle-income countries. We'll take a look at some work his team has done around antibiotic stewardship in Argentina, and we'll zoom in on some specific hurdles in settings with limited resources. The views expressed on the show are mine and those of my guests. So Facundo, welcome to Mapping Healthcare. I'm so happy that you're here to talk to us about a really important topic that's basically the overuse of antibiotics, antimicrobials, especially in settings where this gets to be a real problem. We're specifically talking about some of the work that you've done in pediatric intensive care units in Argentina. And to set the context, nearly 50% of antimicrobial use globally is considered unnecessary or inappropriate. So this is clearly an important topic. Your paper, Optimizing Antibacterial Utilization in Argentine Intensive Care Units, that you published with your colleagues, has some really rich information about the challenges and the successes of implementing antimicrobial stewardship programs, so appropriate use of antimicrobials, such programs in less resource settings, which tend to have a higher rate of intensive care unit acquired infections and resistance to antibiotics. So tell us, what were some of the driving factors for initiating this collaborative, specifically in public ICUs in Argentina? What unique aspects of the Argentine healthcare environment influenced this work?
Well, one of the reasons we launched this collaborative in public ICUs in Argentina is that these units were hit especially hard by healthcare-associated infection and antimicrobial resistance. Compared with high-income countries, ICU in middle-income countries and low-income countries like ours see almost 3 times more ICU-acquired infections, and antibiotic resistance is a daily challenge. For that reason, we need obvious things. Patients in public hospital were facing high risk, teams were often working with fewer resources and heavier workloads. For that reason, well, these ICU need help. And also, we have the COVID-19. ICUs were under tremendous pressures at that time, and antibiotic use increased sharply, often out of precaution rather than clear evidence of bacterial infection. At that time, even though true bacterial co-infection rates were relatively low, almost 3/4 of hospitalized COVID patients received antibiotics. And we saw this tremendous mismatch, and we made clear that we need stronger practical stewardship strategies that fit real world ICU conditions. In Argentina, we have very unique features about healthcare environment that shape our approach. First, public ICUs face resource constraints, but also have highly committed professionals who are used to working in challenging contexts. And second, antibiotic availability can fluctuate here. In low and middle income resources, it's not so good less prescribing, because always it's not a good signal. Sometimes it simply reflects shortages. That means stewardship has to be adapted, not copied from high income countries. This is where our main objective, main aim in this collaborative.
Yeah, so clearly the context of where one works influences antibiotic prescribing. As you mentioned, you can't just use approaches that other countries have used, because their background in terms of what the resources they have really differs. And your study aimed to improve antibacterial prescriptions by reducing overuse and promoting the use of narrower spectrum antibiotics. And before you started on this work, you interviewed healthcare professionals to identify barriers and facilitators. And what did you find were the most challenging barriers, and how did this work attempt to address these human factors?
The most important one was the lack of communication and cooperation between healthcare workers groups. This was very hard because they work in silos. The resistance to change, that is very similar in all the quality improvement efforts. It was very difficult to have the perception that the existing practices are aligned with the intervention that we propose. We understand that the workload pressure could hinder maintaining changes post-study, and we have to think in sustainability from the first encounter with these teams. The facilitator we used to try to pass this barrier was try to base our efforts in previous training in research and try to understand the previous experience with similar study for some healthcare workers. And we have a very hard commitment with the healthcare workers to try to change these stewardship things. Other thing that was very, very important were the learning sessions and the experience change, that where the different teams from the different ICUs could share their efforts, the way they implement the ideas of change, and sometimes implement a new one that were not previously taken into account.
And this work has provided you and your team with a deep knowledge of the challenges of healthcare delivery, especially in Latin America. So you chose a quality improvement collaborative model, and it's this framework that's based on the Institute for Healthcare Improvement, or IHI Breakthrough Series. So tell us about how you implemented this quality improvement collaborative model for this work, and why you considered it the most effective way to disseminate evidence and learn across these 9 different public ICUs in Argentina.
These quality improvement collaboratives have really become one of the go-to ways for teams to learn from each other and improve care. This idea of quality improvement collaborative gained momentum in, I think, mid-90s when the Institute for Healthcare Improvement introduced what they call the breakthrough series. And the concept was pretty simple. Bring a bunch of clinical teams together for about 6 to 15 months. We use sometimes more time, 18 months, and focus on one specific problem, in this case, the stewardship with antibiotics, and help them learn and test changes quickly. In this collaborative, you typically begin by bringing in subject matter experts who help it set a clear, ambitious goal, outline how to measure progress, and sketch out a theory of change, essentially the roadmap for how improvement should occur. In our case, we use the Society of ICU Physicians and the Argentine Society of Infectious Disease. These two societies bring together some subject matter expert and help us to build our theory of change. Then the clinical teams that join this collaborative commit to share the goal, but adapt it to their local context. This is very important, the adaptation to the local context. Sometimes we do some pre-work. Teams attend few learning sessions, one per month. They run multiple plan, do, study, act cycles. They participate in monthly calls, but they also receive one-to-one coaching and also submit data to a shared platform. That shared piece is I think, is the key, because everyone see in real time whether the change they are making are actually improving outcomes. We use run charts to try to show the different teams their progress.
Yeah, and you described an approach to quality improvement in healthcare that's evolved and really scaled up through the past few years, that is using plan, do, study, act cycles. These are these rapid iterative tests of change where you test a change idea and adapt it to your context. And the interventions you used as part of this project were multifaceted. They include guidelines for specific intensive care units, pharmacy-based interventions, and education of clinicians. So there were many change ideas, and one of them really has, struck a chord with me, and that's the antibacterial timeout. Let's talk a little bit about this specific change idea. Tell us how it was practical for you, how it impacted teamwork, how this shifted the prescribing culture in these intensive care units.
This is basically a planned pause. We stop usually after 24 hours of starting antibiotics, where the clinical team step back and ask, okay, now that we have more information, are we using the right antibiotic, or do we even need antibiotics at all? By that point, you usually have culture results, rapid tests, and a clear picture of what's going on with the patient. The timeline centers on 4 simple but powerful questions that help guide safer, smarter antibiotic use. The first of these 4 is, does the patient really have an infection that responds to antibiotics? In other words, we are trying to answer how the patient is evolving. Does the story still fit a bacterial infection, something antibiotic can treat, or could this be viral, inflammatory, or something else that doesn't need antibiotic? The second question is, did we get the right cultures and diagnostic? This is a check to make sure we've done the testing we actually need. If cultures weren't collected before starting antibiotic, or if key tests are missing. This is the moment to fix that, so we are not flying blind, to try to understand why we put antibiotics. The third one is, can we stop or streamline the antibiotics? Sometimes the timeout tells you the patient doesn't need antibiotic anymore. Other times you can de-escalate. switch to a narrower spectrum drug or move from intravenous to oral if the patient is improving. I think the idea is to use the less antibiotic necessary to get the job done. And finally, the last question is how long do they really need treatment? Here we think about total duration, not just the hospital stay, but any treatment after discharge. A lot of infection need shorter courses. We are trying to move to shorter courses of antibiotic use. And this is a chance to make sure we are not over-treating patients.
This project worked a lot on antibiotic de-escalation, and specifically, as you mentioned, it's a strategy to reduce the spectrum of antibiotics by switching from a broader spectrum antibiotic that would kill a wide range of pathogens to a narrow spectrum antibiotic that works best for that particular problem, and stopping unnecessary antibiotics after the recommended treatment period has elapsed, shorter courses of antibiotics, shifting from IV to oral antibiotics if that's right for the patient. So these are antibacterial de-escalation strategies that your work really promoted. And your efforts resulted in antibacterial de-escalation rising from 45% to 62%. So a good amount of change in implementing de-escalation practices. So in your view, what core elements of the work you did? Was it the guidelines, the antibacterial timeouts, or the focus on teamwork? What aspect of this work was most responsible for this increase in timely de-escalation of antibiotics?
Honestly, it wasn't just one thing. It was a mix of intervention, but I think the game changer was getting everyone around the same table. The infectious disease specialists, the pharmacists, the nurses, and the ICU physicians. We used what we call a handshaking stewardship model, meaning the team had to talk about patient face to face at least once a day. And if it was the weekend, they still had to connect by phone. That daily touch point really shifted how decisions were made. There is a big study that were done in Europe, Jorro-Baron F. This was a big one, more than 300 ICUs. And they found that antibiotic de-escalation happened in about 52% of patients within the first 24 hours of blood cultures. We were near 45%. And we were able to push that number even higher, and we did it in a public hospital system in a middle-income country, different from Europe. We showed that what's possible with different teams are aligned with the project. And I think more than 70% of the ICUs focus on communication and teamwork. Within the team and across the team conversation made a big difference. When people start talking more and listening more, everything from decision making to patient care just improves.
So, really good point about a multifaceted approach and everybody sitting around the same table. Here you have increased collaboration, which I think could be the secret sauce to some of this work. And as a faculty member at the Institute for Healthcare Improvement in the United States, and also as a researcher at the Institute of Clinical Effectiveness and Health in Buenos Aires, your past work and this paper have some important lessons for future teams implementing similar programs in less resourced countries. So, if a new team in a similar resource constrained setting were to try to replicate your success related to this intervention, what is the single most important lesson or piece of advice you would give them?
Based on everything we learned, we pulled together a few recommendations for teams that want to launch a stewardship project or any type of collaborative improvement effort. First, make sure everyone really understands what the project is about. That means keeping the objective very crystal clear through ongoing training and regular check-ins with the coordinators. Do a good gap analysis early. Basically, look at what you're really doing, compare it what the project is asking for, and figure out where the differences are. It helps people understand why change is needed. Then think about engagement. Not everyone works Monday to Friday in regular hours, especially in hospital. So training and communication need to adapt to night shift, weekends, and even rotating teams. And of course, it's always the resistance to change. And it's normal. You have to understand that it's normal, that will happen. And so you need a strong leadership that helps people see the value of intervention rather than feeling like it's an extra work. One thing that made a huge difference for us was bringing medical and nursing teams together for joint training. When people actually understand each other's roles and pressures, collaboration gets a lot easier. Also, regular multidisciplinary meetings help create a space where teams can share concerns, compare notes, and sometimes solve problems together. And also having clear communication channels like structured handovers or shared electronic tools. This keeps information from falling through the cracks. And finally, we also suggest having a clear way to deal with conflicts when they come up. They are inevitable, but if you have a process, they don't derail the work.
So your team clearly worked really hard to implement this initiative and it was successful. But a big issue that we face in healthcare improvement initiatives is sustaining that work. And so your work was co-designed using a human-centered approach to manage and sustain change. Consider the barriers that you identified, especially workload and low motivation. What ongoing strategies do you think are needed to ensure the long-term sustainability of some of the practices that your team helped improve?
Sustaining improvement in large quality improvement collaborative really comes down to building structures that outlive the initial project energy and that start on the first day of the collaborative. When teams think about sustainability from the beginning, they design intervention that fit naturally into existing workflows, identify early who will own the work long term, and also choose measures that can be tracked easily after the collaborative ends. You have to invest early in local champions, integrate new practices into routine processes, and create simple feedback loops. Help teams keep seeing their own data over time. And also try to maintain a sense of community with regular cross-site check-ins, share stories between the different teams, and try to make the teams stay connected with each other. And finally, sustainability improves dramatically when leaders commit resources to protect, for example, time for continued measurement and problem solving. And when people feel the ownership, see progress, and have support from above, the gains don't just last, they keep growing.
For sure, you brought up some really important points to maintain improvements following quality improvement learning collaboratives. So these are approaches that connect people and connect organizations to a common goal in a specific area of healthcare. And in this case, improving the use of antibiotics in intensive care units, this approach clearly worked for your team and the hospitals that you worked with. And talking about connection, we close each episode of Mapping Healthcare by talking about the place our guest is from or connected to. And you live and work in Buenos Aires, Argentina. So tell us a little bit about a couple of activities, experiences, or foods a visitor to Buenos Aires should check out.
Well, if you are visiting Buenos Aires, there are a few experiences you really shouldn't miss. Maybe you could start on San Telmo on Sunday with tango in plazas, street performers, antiques. It's one of the most iconic places in the city. Then you could head to Palermo, where murals, cafes, and boutiques give you the perfect mix of creativity and laid-back energy. But for a true local experience, you have to check out a milonga. There are a lot of ones in Buenos Aires. The most famous one is La Viruta, and you could try an authentic tango there. And of course, well, this is a city built on passion. So catching a football match where we have a famous team like Boca, River, Independiente, is it an unforgettable way to feel the pulse of Buenos Aires. And when it comes to food, you can go wrong with the traditional asado, fresh empanada, also a glass of wine. Malbec is very famous here in Argentina. And finishing with a world-class helado from a spot like Cadore or Rapa Nui. Buenos Aires rewards slow walking, late nights, and good conversation. So immerse yourself and enjoy.
Good conversation. And you mentioned Milonga, that's a social dance party for Argentine tangos. So lots of opportunities to create social connections with people around you in all of these experiences that you mentioned. I learned a lot from this work that you've done, and I really appreciate your dedication to making sure that healthcare teams make use of the current evidence that's in the literature and translate that evidence to their clinical practices at the front line.
Thank you for the invitation, Ulfat, and it was great to be with you in Mapping Healthcare.
So that was Dr. Jorro-Baron telling us about an approach that his team took to change clinical practices in intensive care units in public hospitals in Argentina. We saw that there were many challenges along the way, and we deal with much the same issues in the United States. Not setting aside funds that can support the time of pharmacists and infectious disease specialists to do this important work, time constraints, entrenched clinical practices, and communication and care coordination issues unique to specific hospitals, health systems, or regions. Resistant infections lead to longer illnesses, longer hospital stays, higher costs, and more deaths, threatening modern medicine's ability to perform surgeries and manage infections. As we can see, the fight against antibiotic resistance deals with some resistance of its own. And like most resistance, it too is local. I'll leave you with one more thought that connects antibiotic stewardship to our long-term health. When we talk about bringing down exposure to unnecessary antibiotics, especially in our littlest babies, we are investing not just in fighting resistance in one person at one time point. We're actually reducing risks for a host of conditions in our communities for decades. Overuse of antibiotics changes the makeup of our microbiome, the vast community of helpful bacteria and their genes that live in our body and that play crucial roles in our digestion, immunity, and overall health. So investing in antibiotic stewardship programs ultimately shapes the health trajectory of people and populations. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. You can connect with the show on Instagram at Mapping Healthcare if you'd like to share your thoughts and ideas for future episodes or guests. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts. If you enjoyed this episode, please don't forget to subscribe and leave a review.